make yourself loud or whatsoever. So the presentation will last around 35-40 minutes. If there are urgent questions, I think I can try to answer them immediately. Otherwise, we'll have enough time afterwards to go through one or the other question. I would like to apologize that I don't speak Spanish, but I hope that either my English is kind of understandable or that the nice translator will translate it into Spanish for your better understanding. I would like to start with a brief introduction into the product before we'll speak more about the therapy. Cytosorb is an adsorber. It's a cartridge which is filled with highly biocompatible little polymer beads. The beads have numerous pores on the surface, and each bead can act like a tiny sponge to remove substances from the blood. And this removal is based on the process of adsorption. So it's not a filtration, it's no filter, it's adsorption, it's the attachment onto a surface. And importantly, this surface, or the relevant adsorption surface, is located in the inner of the beads. This surface is rather huge. When you measure it, you come to around 45,000 square meters, so 4 to 5 football grounds of size available for the attachment of various substances. To get there as a substance, you have to be small enough to enter through the pores on the surface to enter the beads. And that's why a size-selective adsorption for substances of up to around 55 kilodalton is present. Additionally, the substances have to be rather hydrophobic to develop the necessary adsorption interactions. So that's one kind of selectivity which is given for Cytosorb. The other selectivity is based on the concentration, because a so-called concentration-dependent removal, some say also autoregulation, is also present with Cytosorb. This provides the fact that a high removal efficiency is only given in elevated concentrations, and the more only moderately elevated concentrations or even normal concentrations of a substance are there, the lower the removal efficiency of Cytosorb. All this is important, especially in regard to the safety, and is supporting a very favorable safety profile of the device. Due to the size selectivity, there's no substantial removal of albumin because it's too big, no removal of coagulation factors and immunoglobulins because they are too big. Due to the concentration dependency, there's not a complete removal of physiologic mediators, and so a physiologic, a normal, a needed response is restored, is still given. Also this, I think, is very important. Due to the high biocompatibility of the beads, there's no activation of the coagulation or complement system, and only a very low loss of platelets directly related to the adsorber. All this is further supported by the latest interim analysis of Cytosorb registry. This is a registry which is run by Professor Brunkhorst from Jena in Germany. It's independent of the company and trying to collect all the everyday experiences with Cytosorb therapy, not only in cardiac surgery, but also in the other fields of indication. And this latest interim analysis is covering around 1,000 patients. And here the manuscript is currently under preparation. They report no treatment-related adverse events for Cytosorb. And generally speaking, up to now, there are more than 88,000 treatments performed worldwide with Cytosorb therapy in a wide variety of critically ill patients. I think the cardiac surgery part should make up for around 40% of this. When we do look at the elimination spectrum, you find a variety of substances, first of all cytokines, but also very important trigger substances of the immune response, like the so-called DAMPs and PAMPs and other substances. I'd like to mainly concentrate on the first three, as this is providing the rationale of using Cytosorb in systemic hyperinflammation, or more clinically speaking, in situations of vasoplegic shock. It's quite well known from sepsis that an infection can lead to a cytokine storm, which is then providing the base for the development of a vasoplegic shock and can further deteriorate into a multi-organ dysfunction syndrome. But it's also well known that also sterile triggers like major trauma, major burns, or major surgery can result in a very similar cytokine storm with a very similar clinical picture. And here, cardiac surgery, due to various reasons, is quite well known to be one of these potential triggers of a cytokine storm. So Cytosorb therapy can be used to address this cytokine storm, to manage this cytokine storm. However, as opposite to sepsis therapy in cardiac surgery, you have actually two approaches, because you know when a cardiac surgical intervention takes place. So in cardiac surgery, in regard to hyperinflammation, you have not only the therapeutic approach you normally do post-operatively on the ICU, and I will have some words on this about it as well, but only a brief mentioning of this approach. I'd rather like to concentrate in the coming minutes on the preventive approach. It has a bit of a therapy in it as well, but it's mainly a preventive approach which is used intraoperatively. And the major idea here is to use Cytosorb therapy in cardiac surgery patients when it might get stormy. So the situation might not be fully out of control yet, but you know, due to a variety of factors, there's a certain risk for the development of an overshooting inflammatory response, which is tried to be illustrated here. And you try to prevent this overshooting inflammatory response by the intraoperative use of Cytosorb therapy. Technically, Cytosorb can be installed into this cardiopulmonary bypass. As a bypass, not in the main line, because the Cytosorb blood flow should not exceed 700 milliliters per minute, as then you would have an increased risk of hemolysis. But if you set it up this way, this is just a general example, so perfusionists have several ways of doing it, but generally as a bypass of the main circuit, which results normally in a flow of 10 to 15% of the main circuit flow through Cytosorb. The anticoagulation does not have to be altered just because Cytosorb is additionally part of this cardiopulmonary bypass. So you can keep the same levels you normally target when running a cardiopulmonary bypass by itself. There have been some first pilot trials to test this preventive approach of intraoperatively using Cytosorb therapy with rather small patient numbers. And those trials were primarily meant to show the safety and the feasibility of this approach. And both aspects could quite well be confirmed by those publications. So safety was confirmed, as the authors could show that there was no relevant loss of albumin and also no relevant removal of coagulation factors. And also feasibility could be confirmed because the studies did not report any technical issues during the integration of the adsorber in the cardiopulmonary bypass. A quite recent publication further supports this safety aspect by stating that adding an additional surface to the circuit, which is admittedly in principle quite large, this additional surface, but the relevant blood cells do not get into contact with the surface. That's why it's rather safe to additionally have this surface in the CPB circuit. And as the authors could show here, the device had no effect on the systemic immune cell activation. The question, of course, remains, what was the clinical outcome? And here, those first pilot RCTs have rather shown that the patients who benefit most still need to be identified, or in other words, were not included in those studies, because here those studies rather choose relatively healthy, normal cardiac surgery patients. And the primary procedures which were done was pure CABG surgery. I don't want to talk down the complexity of CABG surgery, but you know that there are more complex cardiac interventions. And of course, not every cardiac surgery patient is relatively healthy. So what we need is additional triggers. And those triggers, to our current understanding, are listed on the next slide. Currently, we see as triggers for the intraoperative use of Cytosorb therapy the following four conditions or aspects. First of all, surgical complexity. I will explain every single aspect in more detail in the coming slides. Then a pre-existing hyperinflammation or a certain patient comorbidity. So if the surgery might not be complex, then maybe the patient has a lot more to bring along than just a cardiac problem. And last but not least, a relatively new indication, which is the risk of bleeding complications. This is not necessarily anything has anything to do with hyperinflammation, but it's a very promising field of use intraoperatively as well. Let's start with the surgical complexity. We know, as I said in the beginning, that cardiac surgery has potential triggers to stimulate the immune system. The cardiopulmonary bypass has a certain bioincompatibility which can result in a dysregulated immune response. This is due to the surgery, this is due to the anesthesia, but this is also due to the CPB by itself, the material, the perfusion, the suction, the shear forces, the contact with the materials, with air, and so on. There are first promising case studies available in regard to the use in transplantations. In principle, it might also make sense to use Cytosorb therapy in complex redo and combination procedures. The most evidence so far we do have, however, in the field of aortic surgery. And this is why I share with you a very nice study covering nearly, or having looked at nearly 700 patients that underwent aortic surgery together with a hypothermic circulatory arrest, which is another trigger for the immune system. Out of this nearly 700 patients, 176 have received intraoperative Cytosorb use, and those were compared with more than 500 control patients. And after a propensity score matching, we found nearly 170 patients on each side to be compared. The key finding was that the use of Cytosorb during aortic surgery was reducing the need for vasopressors, was providing a more stable metabolic situation, and was providing less need for transfusion without any adverse events. And a very interesting group of this 170 to 170 patients was especially the group with acute aortic syndrome. Here you see that quite some patients, or the majority, had an aneurysm. This is more a kind of elective surgery, where the patients also kind of benefited from the intraoperative use of Cytosorb therapy. However, those patients with this acute aortic syndrome, so those patients with aortic dissection, seem to benefit even more of this setting. And when you compare those aortic syndrome patients, the control patient, the hemoadsorption, here we have 46 on each side, you saw that, especially in regard to transfusions, there was a significant difference. And this made the author speculating that this significant reduction might even compensate for the cost of the device. They even showed other effects on cerebral oxygenation, but this is so far only available in a German abstract and not yet part of a publication. But to our understanding, the authors will further analyze all those results. It's a huge database and are working on upcoming publications. We have also first results from India when Dr. Mehta, he presented this last year at the EACTS Congress in Lisbon, and he did a pilot study comparing the intraoperative use of Cytosorb in patients undergoing major aortic surgery with a control group, and the patients with Cytosorb, the patient group here, it was associated with decreased levels of inflammatory mediators, better hemodynamics, a reduced duration of mechanical ventilation, and also a decreased ICU and hospital length of stay. And we hope that all this is further supported soon by a case series from Zurich University Hospital. They are using Cytosorb kind of on a regular basis whenever it comes to any aortic dissection. Intraoperatively, they use Cytosorb therapy, and they are currently analyzing retrospectively their results with having used Cytosorb therapy in all those patients with in comparison to control groups, historical control groups, when Cytosorb was not yet used in such a routine way in this hospital. And the plan is to analyze or compare around 100 patients with intraoperative use of Cytosorb therapy and 100 patients without Cytosorb therapy. So this is some brief words on surgical complexity, or specifically on aortic dissection, as a very promising field of indication for Cytosorb therapy. Another promising field, and possibly even number one in all this setting, is endocarditis, or a bit more general, is a pre-existing hyperinflammation. So here, it's not only a pure preventive aspect, it's also a kind of therapeutic aspect, because the patients bring along a certain activation of the immune system. This can happen in shock states, as we know that also shock can trigger the immune response, but also in endocarditis. So the patients have a certain level of hyperinflammation, which will then further escalate due to the surgical intervention, due to the well-known bacterial spread out, and also the spread out of other important DAMPs, so damage-associated patterns like, for example, cell-free DNA and others. And the intraoperative use of Cytosorb is meant to prevent this further escalation and also to treat kind of the pre-existing hyperinflammation. Interestingly, or from a theoretical point of view, Cytosorb can be especially important or helpful in cases of a gram-positive endocarditis, because as this absorption spectrum shows, Cytosorb therapy is capable of removing various bacterial toxins. So in case of a gram-positive endocarditis coming from Staphylococcus or Streptococcus infection, it might be that Cytosorb is acting on two levels. On the one hand, as an immunomodulator, plus as a detoxification by removing the toxin of gram-positive bacteria. This has not been, of course, proven in detail that this exactly is making the difference, but at least this is some theoretical consideration, which has also been brought up by one or the other author. Let's have a look at what's published in endocarditis. And here we have quite some publications available. I will go through some of them, but not through all. And I'd like to start with making you aware of a very important and very interesting RCT. This is the so-called REMOVE study. That's a publicly funded endocarditis multicenter RCT, which has been run in Germany in more or less 15 to 16 hospitals. The primary outcome is the change in the SOFA score. The secondary outcomes is the vasopressor levels, other DAMP levels. You find more information on this on clinicaltrials.gov if you want to learn more in detail about it. All patients have already been recruited, so they have made it to recruit more than 280 patients, because in the end, after potential dropouts, they want to have 250 patients overall for the final analysis. So comparing this into two groups, control group and intraoperative Cytosorb group. And the first results we will hopefully hear and see in Q3 this year. This was all planned to be available by Q2, but also in Germany, the COVID pandemic slowed down things dramatically. So of course, they are a bit delayed, but still, I think there are good chances that they get their analysis done in the course of this summer. Let's have a look at other publications. There's a quite nice case series from southern Germany from Professor Traeger from Ulm. He has looked in a retrospective manner at 39 patients with acute infective endocarditis. It was the aortic valve or the mitral valve, and compared this to a historic control group of 28 patients. And he could not only show cytokine reduction, but also an unexpectedly rapid improvement of the hemodynamics and organ function. And by comparing the length of stay on the ICU, the median levels, he could see a reduction in the Cytosorb group, or a shorter length of stay in the Cytosorb group versus the control group. A relatively recent publication is coming from Essen on Cytosorb patients in mitral valve endocarditis, infective endocarditis of the mitral valve. Here they looked over 4 years at nearly 60 patients. 30 of them were treated intraoperatively with Cytosorb therapy, and 28 served as a control group. The two patient populations, despite not being an RCT, were quite comparable, and the primary outcome was the occurrence of sepsis or sepsis-associated death. And here the hemoadsorption group could show quite some nice differences and benefits in this regard. So the intraoperative hemoadsorption, as the authors also stated, may reduce the incidence of postoperative sepsis and also the sepsis-associated mortality. Next to this, they could show effects on the hemodynamic stabilization, which is generally one of the most well-known effects of Cytosorb therapy, to have a lower need for vasopressors, to have a lower level of lactate levels, a better systemic resistance, and also better metabolic stability. So conclusion is here that due to all this, all these data suggest that the intraoperative hemoadsorption may improve surgical outcome. And as I said, we hope that the results from the REMOVE study will further support this approach. There's one kind of still open question, and this is, should I continue Cytosorb therapy after surgery? So should I continue my intraoperatively started Cytosorb treatment postoperatively on the ICU? And to try to answer this question, at least as a first step, there was a nice comparison done from a recent publication in Germany. They took 20 patients with endocarditis and had 10 patients that were treated only intraoperatively and compared those with 10 patients who were also treated postoperatively, so as well as. And the decision to continue Cytosorb treatment postoperatively was based on the clinical grounds. This was on the one hand, the presence of acute kidney injury, so the presence of CRRT as a host circuit, but also the presence of hemodynamic instability. Also, it's not listed here, the presence of quite profound vegetations by visual inspection during surgery. When all this was given, the surgeons decided to continue with Cytosorb therapy in those patients postoperatively. So one can say that this group was definitely sicker than the other group who were more stable by purely having used Cytosorb intraoperatively. In both groups, they could show a marked decrease for vasopressors and inflammatory markers, and the ICU and 90-day survival was also the same, but taking into consideration that the one group that continued Cytosorb treatment postoperatively was the sicker group, one can at least speculate that the post-op continuation of Cytosorb might be beneficial. I think we need more investigation for this. So far, I think it's a very promising indication for the intraoperative use of Cytosorb therapy, endocarditis I mean. However, one should not forget that in one or the other patient, it might also be advisable to continue the therapy postoperatively. One last word on a patient or on a potential trigger for indicating Cytosorb therapy intraoperatively. However, this has not been very well investigated so far, and this is patient comorbidity. As I said, it can either be the surgery or it can be the patient. And here, specifically, acute or chronic kidney and or liver dysfunctions are in the focus for Cytosorb therapy, because Cytosorb therapy has shown to be a very potent remover of liver toxins. So Cytosorb has even been superior in first investigations than classical liver support technologies. We have quite nice experiences with having treated cardiac surgery patients would have a certain degree of liver dysfunction. However, this is not yet very well documented and not even analyzed, but in principle, liver patients undergoing cardiac surgery can represent a quite interesting group for the intraoperative use of Cytosorb therapy as well. And a similar approach is given for rhabdomyolysis patients or generally patients who require a bit of renal support. I mean, Cytosorb is not a renal replacement therapy, but one or the other substance which is also harmful for the kidneys, like for example myoglobin, can also be removed by Cytosorb. Last but not least, for the intraoperative use of Cytosorb, I like to speak about the risk of bleeding complications. As I said, this is a relatively new indication, and strictly speaking, this has nothing to do with hyperinflammation, but it's also the intraoperative use of Cytosorb therapy. And this is specifically given for patients on ticagrelor or rivaroxaban therapy in emergency cardiac surgery. All this started with in vitro results having shown that Cytosorb is very capable of removing ticagrelor or rivaroxaban from the blood. And then some doctors in Hamburg made their clinical experiences by testing it, by using Cytosorb therapy intraoperatively in those patients who underwent emergency surgery and had a pre-existing treatment with either ticagrelor or rivaroxaban. Overall, they had 55 patients between 2016 and 2018. The majority of them had a pre-existing treatment with ticagrelor. However, there were also 12 patients that were on rivaroxaban before they had to have the surgery. And then 39 of them received intraoperative Cytosorb treatment, and the 16 patients who did not receive Cytosorb treatment were in the beginning rather by chance, because it was not a prospective RCT, it was just that they started to use this approach. One surgeon was more familiar with it than the other, so some patients did not receive Cytosorb therapy, at least in the beginning, because meanwhile they only use Cytosorb therapy for those patients. But for a while, there were some patients without Cytosorb therapy, and those patients served as a control group. And here you see in the last line the final split up, so 32 patients intraoperatively with ticagrelor, 7 patients intraoperatively with Cytosorb and rivaroxaban, and 11 and 5 on the control group side. And now let's have a look at the results, or at the analysis. This is first of all a list of the surgical procedures. So in the majority of the cases, it was CABG surgery. The first difference was, and this was noted by the surgeons immediately, that despite the fact that the cardiopulmonary bypass time was very much comparable, the procedure duration was significantly shorter in the Cytosorb groups than in the groups that did not have any Cytosorb therapy, because there was by far less time needed for controlling the bleeding after weaning of the cardiopulmonary bypass. And this was also shown or seen in the fact that by far fewer patients needed transfusions. So here, nearly 80% of the ticagrelor patients did not require any transfusion of red blood cells, whereas this was only given for 50% of the patients in the control group. In rivaroxaban, the difference was even more pronounced. I mean, there are smaller numbers, so one shouldn't overrate it, but anyhow, 85% did not require any transfusion, which was not given at all in the CPB only group. And a similar pattern, even more pronounced, was given in regard to the transfusion of platelets. Here, 60% without any transfusion platelets. Every of those 11 ticagrelor control patients needed transfusions, and also every of the 5 rivaroxaban control patients required transfusion of platelets. And as a more objective measurement, you can also see here the differences in the drainage volume over 24 hours, which was significantly different whether or not the adsorber was used. This led to further clinical outcome differences. First of all, the rethoracotomy rate, which was not needed in all the Cytosorb patients, but up to 40% in the other patients. Of course, this is only speaking about rethoracotomies due to bleeding complications. And all this resulted then also in a shorter length of stay on the ICU and a shorter total length of stay, which might then also translate into economic aspects or benefits. And the authors conclude that this approach of intraoperatively using Cytosorb hemoadsorption in emergency open heart surgery is very safe and effective to reduce the bleeding complications and improve outcome, which is why they recommend the use of Cytosorb in those patients. And this is meanwhile also covered by the CE certificate. So this was a brief introduction into using Cytosorb intraoperatively with the target of increasing or regaining intraoperative stability as a kind of preventive therapeutic approach. There's also the pure therapeutic approach with the target of shock reversal. Just some brief words on it. I don't want to go too much into detail here for the sake of time, but this is an approach where it's not any question any longer that it's storming. So it might be stormy, might get stormy. It is storming already. And here Cytosorb is used to lower highly elevated levels of cytokines back to a more normal, moderate level. Clinically, those patients are quite vasoplegic, and this vasoplegia is refractory to standard therapy. This can be given in a couple of settings, of course, in vasoplegic shock, but also generally post-CPB in ECMO patients. And here the goal is really to achieve hemodynamic stabilization again, to achieve shock reversal, attenuate hyperinflammation. Technically, you have other systems you can use Cytosorb with, so not the CPB, but the ECMO, the CRRT, and even, which is not shown here, a standalone hemoperfusion mode is possible. The same in regard to blood flow and anticoagulation applies. And just some last word on the therapy in this field. It's important to know or consider it's an adjunctive therapy. So it's not replacing the other measures you are doing. It's not replacing the organ support in principle, the source control, other resuscitation measures, but it might be an add-on if the standard therapy is not good enough to control things properly. And to control things for Cytosorb mainly means to control hemodynamic stabilization. And having said this, I want to come back to the intraoperative use with a brief summary. Intraoperative initiation of Cytosorb therapy has the goal to reduce the risk of inflammatory activation. And to our current understanding, these are the aspects which might make you consider Cytosorb therapy to be used in your patients. And the two most promising ones and the most well supported with the evidence with publications are acute infective endocarditis and aortic surgery, especially. This is the way or the results or how the way the doctors from Munich meanwhile do it if there's a prolonged hypothermic circulatory arrest time to be expected of more than 20 minutes. One aspect is still missing here because our marketing material has not yet been updated as we received the CE approval only shortly. The other aspect of, or the other potential criteria for using Cytosorb intraoperatively is with the goal to reduce the risk of bleeding complications in patients with ticagrelor or rivaroxaban therapy and who undergo emergency cardiac surgery. With this, I'm at the end of my talk. I hope I kept the time as you expected it to be. If you want to learn more about Cytosorb, I encourage you to have a look at our Cytosorb literature database. This can be found on our website, and there you'll find all the publications available regarding Cytosorb. Of course, not only cardiac surgery, but you have different tags to filter the search results, or you have a free word search to specify what you are specifically looking for. Currently, we have more than 600 or 700 entries here. And this is a good way of learning more about Cytosorb therapy. You can have a look at clinicaltrials.gov. Also, we are on a learning curve. We also learn every day anew by feedback from the users. I think the development, which is shown here, is very nice. As I said, nearly 90,000 treatments so far overall for Cytosorb therapy. With this, more and more documented patients, more and more documented treatments, more and more publications, more than 100 meanwhile already in a peer-reviewed journals. And the registry is also growing bigger, and every center is encouraged to participate and share their experiences with the registry. And last but not least, we know that clinical trials are needed. I presented you some approaches, the REMOVE trial. There are other approaches also in endocarditis planned or even ongoing. You find a list on our website as well as on clinicaltrials.gov. And having said this, I thank you once more for your attention, and I'm open for all your questions. Thank you.
Thank you very much, Dr. Humbert. Muy agradecido, Dr. Humbert, por la charla. Muchas gracias al Servicio de Cirugía. Muchas gracias al Servicio de Cirugía Cardiovascular del Hospital Almenara por recibirnos. Y le doy la palabra al doctor Delgado para que pueda moderar las preguntas.
Gracias, Dr. Rodríguez. Very nice presentation, Dr. Volker. Thank you very much. Bueno, en realidad creo que nos hemos conversado de una forma bastante amplia de todas las bondades que tienen este tipo de dispositivos absorbedores de interleuquinas o mediadores del sistema inflamatorio. Creo que en centros de cirugía cardiovascular de alto volumen como es el Hospital Almenara, con quien tenemos el gusto de tenerlos esta mañana en esta reunión, pues la cirugía cardíaca va un poquito más allá de pacientes no complejos a pacientes cada vez más complejos, en donde la terapia con Cytosorb nos puede ayudar, ya que la gran mayoría de estos pacientes van más allá de las habilidades quirúrgicas que puede tener el cirujano, ¿no? Más allá de todo esto va la respuesta inflamatoria, que al final a veces pues, cambiando el escenario o cambiando el destino del paciente después de la intervención. No sé si alguno de ustedes, por favor, tendrían algunas preguntas, tendrían algunos aportes respecto a la presentación que el doctor Volker nos ha dado esta mañana.
Sí, doctor, yo tenía una consulta, si me permite hacérsela al profesor Volker.
Dale.
Professor Humbert, I had a question regarding I understand perfectly that Cytosorb is an hemoadsorption device, and it's going to filter in relation to molecular weight. But I wanted to know if there's any other way of filtering or not filtering certain substances, like the ones used, for example, for anticoagulation.
What do you mean with other way? You're exactly right. In a first step, Cytosorb is filtering the blood, because only substances which can enter the beads can reach the adsorption surface. So that's a kind of filtration process, if you want to call it like this,
Yes.
because everything which is too big, like cells or other bigger proteins, immunoglobulins, they cannot enter the beads, so they just bypass the beads. And as the surface of the bead is very biocompatible, they are not affected. So there's not any activation of the coagulation system, of the complement system. However, that's only one criteria. If you then have entered the bead as a substance, you still have to be very hydrophobic, because otherwise you cannot develop the adsorption interaction. If you are a very hydrophilic substance, the substances which are normally cleared by renal replacement therapy, you might enter the beads, but you then just pass through the beads, because you cannot attach to the surface, because you cannot develop these hydrophobic interactions which are needed for the adsorption. So those are two criteria. And the third criteria is the concentration dependency, because normally the substances that Cytosorb targets are always bound to proteins, because they are hydrophobic substances. So they flow in the bloodstream attached to proteins. That's why at normal concentrations, like we have currently with interleukins, those substances are onto the protein, and so they cannot enter the bead together with the protein. The substance might be small enough, but together with the protein, they cannot enter the beads, and so they will not be eliminated. That's why we can never eliminate substances completely from the blood, because at a certain level, the substances in question are always attached to a protein. However, in elevated concentrations, when you have a cytokine storm, then you have many free floating substances, and then they are small enough to enter the beads, and then they can be eliminated. So in the end, it's about size, it's about chemical structure, and it's about concentration. So those are the three criteria which somehow define whether Cytosorb is making any removal or not.
Perfect. And let me extend a little bit the question. For example, in a patient that's operated of aortic surgery, high-end complicated surgery, aortic arch, etc., and you continue the treatment post-surgery, so you keep on Cytosorb use post-surgery, do you use the same criteria as in a sepsis patient? For example, the need of vasopressors, the lactate levels, or is there any other value that we should be checking to see if Cytosorb is or not working? For example, procalcitonin or protein protein C, reactive protein C.
Yeah.
So some centers don't have the availability of dosing interleukin-6, for example.
Yeah.
So is there a way that experts are measuring how the Cytosorb is working, whether or not continue to use Cytosorb? Can you explain a little bit more and expand a little bit more?
Yeah, I will do. So very important questions. Of course, it's also very important whether or not to follow up or to continue Cytosorb therapy. I said so in endocarditis, we have current in discussions, and it seems so that in some patients, you might make things even better when you continue with Cytosorb. I mean, you make a very good impact, to all we know, already with the pure intraoperative use, but you might make it even better when you continue postoperatively. The decision how long to continue or whether to continue is very often based purely on clinical grounds, so on the clinical picture, and this is very much, as you rightly said, about the hemodynamic stability or instability, so about the levels of vasopressor needs, the lactate levels, and here, as always, more about the changes and not the absolute value. So when you feel things are rather increasing in regard to vasopressor demand, then it's a very good sign for starting Cytosorb therapy if you haven't started yet. And in regard to continuing or not, if the vasopressor levels are falling, then you might rather allow yourself to not continue with another adsorber. However, if the vasopressor levels are more or less still on the same level or only going down a little bit, then those might be the criteria to continue with Cytosorb therapy. When you want to measure blood parameters or laboratory markers, as you said, PCT is one of the most popular ones, IL-6, of course, as well. But we know that many centers don't have the opportunity to measure IL-6 or don't get it in a timely manner. And then I think looking at the clinical picture, and here again at hemodynamic stabilization, is very important.
Thank you very much. And then I have one last question because I want everybody else to participate. But I heard Dr. John Kelly, the director for the Center of Critical Care of Nephrology of the University of Pittsburgh, he said in his conference that Cytosorb could remove more than 80% of circulating cytokines in a lapse of 1 to 2 hours. That means that a regular hemodialysis machine would work perfectly to remove about 80% of circulating cytokines. Is that precise? Is that a precise answer?
Those numbers always have to be seen very much in the complete picture. As I said, Cytosorb is concentration, has a concentration dependency. As it's even the higher the levels, the more efficient it is. And in very, very high levels, we have really had very, very rapid reductions of cytokines. If you have lower levels, then the reductions are not longer that pronounced. So when you have this 80%, that's a very high number, I have to say, for cytokines. It might be given if you have an in vitro setup. I think in vivo, you probably don't have 80% in 2 hours. I think this is a bit too rapid. But Cytosorb therapy on the ICU, of course, is normally planned for longer, for up to 24 hours. In the OR, of course, you have a shorter period of time, but generally, we have a couple of publications who come with percentages. It's sometimes 60%, it's 40%, 50%, but this is all very much dependent on the starting level. The higher the starting level, the more you bring things down. And then it's also dependent there. if you look at one IL-6, then this is just, or at one interleukin, or maybe at IL-6, then this is just one single piece. And the cytosorb adsorber is confronted with many different substances to be removed. And also this is, of course, different from patient to patient. So if you want to have exact removal rates, it varies on the one hand on the concentration and also on the other substances which have to be removed as well. That's why it's very individual, and you cannot generally say Cytosorb is always removing 80% within the first 2 hours of IL-6, because in another patient it might only be 30%, in another patient it might be 40%. So it's too individual. But I think the decisive thing about Cytosorb is it's trying to rebalance the immune system. It's removing the elevated concentrations and leaving the not that elevated concentrations rather aside. So it's regaining a new balance, which we think is the most beneficial way, because it's difficult to blame one single factor. It's more or less about dysregulated becoming more regulated, becoming more balanced. That's our approach.
Thank you, Professor.
Invitamos a los asistentes, a los participantes a hacer sus preguntas en español, que van a recibir traducción simultánea. Así que, por favor...
Sí, bueno, bastante interesante las preguntas de Juan Carlos y más aún las respuestas. En la sumatoria de experiencia que usted tiene, doctor, ¿qué porcentaje de pacientes utilizan eventualmente el dispositivo solamente en el intraoperatorio respecto a aquellos que lo hacen en el intra y el postoperatorio?
Was this a question to me?
Yes, for you.
Yeah, I could. It was in Spanish, so I could get a bit of an idea what it was about, but not the full question. It was something with postoperative and so on. But because I didn't receive any translation, or can I click here somewhere to receive a translation as well?
Por favor, repite la pregunta, doctor Delgado, para que lo pueda translate.
Ok. Me preguntaba respecto a los pacientes que reciben el dispositivo en el intraoperatorio y el intraoperatorio más el postoperatorio. ¿Qué porcentaje de pacientes hay para cada lado?
Can anyone translate this to me? Felix? What the precise question was about? I got some things, but not sure whether I really understood.
Doc, ¿podrían repetir la pregunta porque se cortó? No se entendió bien.
A ver, la pregunta era, en toda la experiencia que usted tiene de uso de dispositivos, ¿qué porcentaje lo hacen en el intraoperatorio y qué porcentaje lo hacen en el intra más el postoperatorio?
So, Dr. Humbert, the question is regarding, in your experience, what's the percentage of patients that are benefited of the use of Cytosorb intraoperatively and not intraoperatively? I think
it depends. Thank you. And sorry that I did not fully understand the question beforehand. Thank you for the translation. I think it very much depends on the indication. So on this intervention on which Cytosorb was used. As I showed you, the initial trials were on relatively normal cardiac surgery patients with relatively normal cardiac surgery. Again, I don't want to play down the complexity of cardiac surgery, but this was relatively standardized procedures. And here the patients, they were not harmed, but as trials have shown, they were also not benefiting because they were not in need of any prevention. It's a bit like when you want to prevent things, there has to be a certain risk which you want to avoid by your approach. However, if you were using Cytosorb in what we now know in those indications like endocarditis, aortic surgery, or rivaroxaban ticagrelor removal, I would say that there was a very high percentage of patients really benefiting from this, especially in endocarditis. I would say this goes close to 100%. I mean, in a single case, it's always impossible to really say what would have been the case without Cytosorb. I mean, if you do one patient, the patient has a certain course, and you will never know what would be the course without Cytosorb. But what we know is when doctors have used Cytosorb in endocarditis, they were very much impressed by the hemodynamic stabilization or stability. So the perfusionists were saying that normally this doesn't go that smooth, this doesn't go that easily in other patients. But strictly speaking, every patient is different, so you never know for sure. You can only say so those percentages when you have a control group. And this control group we will have soon, hopefully in the REMOVE trial, when they compared 125 patients with 125 other control patients. So the same with ticagrelor, rivaroxaban. I would say that whenever someone thought about using Cytosorb for the bleeding complication, he or she was very satisfied, but also here, you will never know what would have been the course without Cytosorb. So it's difficult to give a number, but I would say in those indications, there's nothing like 100%, but I would say it's coming very close to that every patient seems to be benefiting from Cytosorb therapy. If this was kind of the question.
Yes, it's
Okay.
perfect regarding the indication. Absolutely clear.
Gracias. No sé si hay alguna otra pregunta del auditorio, por favor. ¿Quiénes tenemos del otro lado en el Hospital Almenara? Hola.
Any further questions? You can also type it in.
Me parece, no hay mucha cantidad tampoco de compradores o en los exteriores de estas zonas donde se generan las colas. Coméntanos un poquito de eso, por favor.
Nosotros primero hicimos el enlace, en la puerta y vimos bastante público. Sin embargo, ya estamos
Pamela, Rocío, Cari, ¿alguno de ustedes quiere hacer alguna pregunta, por favor?
Doctor,
Sí, adelante.
una última pregunta. Professor Humbert, I have one last question.
Okay.
And it's regarding the pandemic that we are all living actually right now. What happens if you have emergency cardiac surgery and the patient is positive for COVID virus? Is that also an indication because of the pre-inflammatory state in which the patient is going into the OR? So if the patient be benefited if we use Cytosorb in cardiac surgery and use COVID positive as an indication for it?
In principle, yes, but of course it's very important to make clear that Cytosorb is no antiviral therapy. So Cytosorb is not killing the virus, deleting the virus from the bloodstream. So as we know, and there have been so far, I think more than 1,000 patients have been treated with COVID-19 and Cytosorb therapy. However, those were always patients that had a hyperinflammation, a cytokine storm present. And this is present in some phases of COVID-19 infection, and it's not present in other phases of COVID-19 infection. So the pure fact that the patient is COVID-19 positive, so that has a positive PCR test for the virus, to me is not justifying the use of Cytosorb therapy. However, as we know that COVID-19 is associated or can be associated with a dysregulated immune response, this of course can serve as another indication or another rationale of using Cytosorb in those patients. But it's important to make clear it's not an antiviral therapy.
Okay, so it's a gray area. We could, depending on the state of the patient and how
Exactly.
inflammation the virus is producing in
If you have clinical features, that point towards hyperinflammation, which is capillary leakage, which is vasodilation, high levels of vasopressor needs. So the typical aspect, if you possibly have elevated laboratory markers pointing towards hyperinflammation, high IL-6, other inflammatory markers elevated, then of course it can be can make sense to also use Cytosorb in those cases. As I said, on the ICU, Cytosorb has been used in quite some number of patients and treatments, and was then also associated with hemodynamic stabilization, was associated with improvement in lung function. I just wanted to be that honest. Just the fact that PCR is positive, so that the patient is a COVID-19 patient, this by itself is not immediately leading to Cytosorb. This would be not scientific. Yeah.
Thank you.
Oh, pleasure.
No sé si tenemos alguna otra pregunta de la audiencia, el doctor Del Hierro, el doctor Delgado.
Bueno, yo creo que más que una pregunta, me gustaría enfatizar un poquito en las ventajas que nos ha comentado ahora el doctor Volker, básicamente centrados en todas las cirugías cardíacas que vayan a más de 120 minutos de circulación extracorpórea. Por lo que nos ha mostrado, los pacientes se benefician del uso del Cytosorb, teniendo un especial interés o un especial resultado en los pacientes que son sometidos a cirugía de aorta o sometidos a cirugía valvular en endocarditis. Creo que son los mensajes más importantes, o cualquier tipo de reoperación, o pacientes que tengan comorbilidades importantes y que vayan a cirugía cardíaca. Y un grupo adicional y por separado, que son aquellos pacientes que vienen recibiendo algún tipo de anticoagulación o algún tipo de antiagregación antes de una intervención quirúrgica cardíaca de emergencia, que se benefician de sobremanera al ver la cantidad de transfusiones, el tipo quirúrgico y la revisión de hemostasia postquirúrgico en estos tipos de pacientes. ¿Ah? Si hay alguna intervención adicional, por favor, por parte del auditorio. De lo contrario, creo que hemos tenido un tiempo suficiente para preguntas, y agradecer al doctor Volker por su brillante presentación el día de hoy.
Muchas gracias.
Thank you for interest.
Si no hay otra pregunta, bueno, agradecemos a los miembros, a los cirujanos del Servicio de Cirugía Cardiovascular del Hospital Almenara. Agradecemos al doctor Delgado por su moderación. Thank you very much, Dr. Humbert, for this, this webinar. Y muchas gracias a todos por su participación, y cualquier cosa, cualquier duda, estamos para absolverlas, y hasta la próxima reunión que tengamos sobre este tipo de terapias y todas las terapias que estamos trayendo para la cirugía cardiovascular. Muchas gracias con todos.
Okay.
Gracias, un placer.
Thank you very much.
Gracias, adiós.
Adiós.